This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh with a very tan Dr. Brian
I
Schmutzler.
don't know what you're talking about. Looks just like normal.
Yep. That's what happens when you get out of sub-zero temperatures into warm weather.
It was warm-ish.
Indiana won the championship, and now you're celebrating with warm weather.
It's warm-ish.
Warm-ish. Warm-ish. We are brought to you by
The Butterfly Network. All right, I'm going to let you in on something that's completely changed the way I practice. I've been using Butterfly probes for years. It's a portable ultrasound that plugs right into my compatible smartphone or tablet, so I can start scanning at the bedside in seconds. If you've used the older versions, or even if you're new to the handheld ultrasound game, let me tell you why this IQ3 is a game changer and really impressive. First off, having an ultrasound that literally fits in my pocket means I can move faster. Whether it's vascular access, procedural guidance, or just getting real-time insights from my patients. And the tech inside this tiny device is pretty incredible. Biplane imaging lets me see short and long axis simultaneously, which is huge for procedural guidance and honestly a great tool for learners. The new needle out of plane preset even shifts the scan plane digitally, so I can see the needle tip sooner, which makes a real difference when precision matters. And the image quality, honestly, the IQ3 holds up against some of the high-end cart systems I've used. That's impressive for something this portable. If you're looking for a device that supports your practice, I can't recommend the Butterfly IQ3 enough. And right now, they're running a special offer. You can get $750 off the latest IQ3. Check it out at butterflynetwork.com. So the Butterfly, I was talking actually to a new client that we're working with, and I did disclose that Butterfly is a supporter of our show, but they were looking for a new ultrasound, and I said, you know, you can spend $100,000 on a big cart system, or a small hospital, or you can get like 3 or 4 of these. So I think they're going to go with the Butterfly.
Hey, look at you
Look at me.
being out there. And all.
That's right. I even gave him my code.
For the $750
$750 off.
Today on this episode, we are talking
something we've never talked about before. Learning all about it. Never heard of them. These new medicines. Sorry, go ahead.
GLP-1s.
Oh, what's that?
GLP-1s. We're going to talk about weight loss in 2026. Is it becoming the new statin? We're going to be talking about injectables versus oral medication. We're going to be talking about muscle loss versus metabolism. We're going to be talking about, is it a forever muscle gain? Is it the forever drug? Do you have to take it forever? Insurance, cost, and access. We're going to be talking about some of the social media stigmas that come with taking, if there's any. And, of course, what doctors wish patients knew before starting.
Oh, my.
The GLP-1. First off the bat, though, Mr. Dr. Brian Schmutzler.
Yes. What is a GLP-1?
No, well, what does it stand for?
Ghrelin-like protein 1, I believe.
Okay.
Actually, glucagon. Sorry. Hang on.
Yep.
I don't even know. It's all
a blur.
It's all a blur at this point.
We've never talked about it before. It's a blur.
We've talked about it a lot, but nobody calls it. It's glucagon-like. Oh my word! I think
everybody calls it Ozempic, even though it's not.
No, they're not all. They're not
all Ozempic, but I feel like people are calling it that. It's a GLP-1.
It is, but it's a brand name. Sorry. We'll get it.
Glycogen.
Glucagon-like peptide 1. So they're actually GLP-1 RAs. So glucagon-like peptide 1 receptor agonists.
So it's supposed to slow down your eating receptor.
So the
hunger.
The way it works for weight loss is that it slows down the transit of food from your stomach into your small intestine. You feel fuller sooner and longer. So that's how it works for weight loss. But they've been used in diabetes for quite some time because they help regulate blood glucose, right? So diabetics take medications to reduce their blood glucose so they don't get the big spikes in insulin because they either incorrectly produce insulin in type 2 diabetes or when their pancreas is burned out, whether from long-standing type 2 or autoimmune early onset type 1, that they don't make insulin anymore. So it's a medication that we've used for a long time. We've talked about these kind of ad nauseum as a society, and even on the podcast, we've talked about them quite a bit. But yeah, they work primarily, at least what they thought initially, is primarily by slowing gut transit. Now, is that totally true? Probably now there's a few other things. There's probably some brain mechanisms. There's probably some peripheral mechanisms. There's probably some other things going on besides just making you full. But the way these came about for weight loss is people who were taking them for diabetes noticed this like 10, 15, 20% weight loss, when they were on the drugs. And so just like any brilliant pharmaceutical company, they're like, oh, that's a great side effect that we could use this drug to promote. So, yeah, go ahead.
Well, I was going to say we've got 8 burning questions that we kind of want to file through
So
here.
what's number one?
So number one is kind of a two-parter. What are we learning in 2026, and is it becoming the new statin?
So what are we learning in 2026? So we're learning a lot of times these drugs that have any metabolic effect have a lot of other metabolic effects, right? So it does probably make sense, this cardiovascular effect that it has. So it reduces cardiovascular risk. The Ozempic, Ozempic, right? The Ozempic trizone. So they've known for a long time the cardiovascular effects are decreased. Now, there's a lot of reasons why that could be. Probably the one that I buy most is that you're reducing circulating blood glucose. Circulating blood glucose turns into triglycerides. Triglycerides go to the vasculature of the heart. They tear up the endothelium, the inside part of the cardiac arteries, and then basically they cause inflammation there. They cause the start of a clot, which would cause a heart attack. So that's probably how they work. But they're also reducing overall inflammation from a different mechanism. Not just that there's less, circulating blood glucose, but there actually is less inflammation in the body overall. How that works, I don't think they're totally sure. But again, reduced inflammation means reduced inflammation in the arteries, which means reduced cardiovascular issues. And then metabolic syndrome makes sense as well because, again, your blood sugar is stabilized, so you're going to have less of this, the metabolic syndrome, which is high blood pressure, high cholesterol, and diabetes all come together to create this metabolic syndrome. One really, really interesting one is the addiction issue, right? And so they find this with a lot of drugs that come out that have other effects. Like for a while, they were using naloxone, which is a medication that reverses the effects of opioids to reduce addiction, right? And so they've done some of this with the antidepressants as well. But, so one of the things that may be happening is that some portion of this or some breakdown product of the GLP-1s go to the brain and activate the center that decreases cravings. So that may be why you eat less, but also decreases dopamine release, which means less addiction.
Okay.
So, some of that is going on as well, probably. All right. So, and then, how much of this is real? How much of it is overhyped? I mean, there's solid studies for the cardiovascular effects, right? So I have zero doubt that that's happening. The addiction stuff is a little less clear, maybe not. One big thing, probably the best data that's out there right now, at least human data, not in vitro data like in a petri dish or a test tube, is increased fertility. So there's a huge increase of people who are infertile or have trouble conceiving and then go on a GLP-1 and get pregnant pretty quickly afterwards. So that's probably the best data that's out there. Is this the new statin? So I think that there's some of that. I think the big problem with the GLP-1s is there's a lot of side effects. So a lot of people can't tolerate the bloating, the abdominal pain, the nausea, the vomiting. And then there's a high percentage, and I can't remember, it may be as high as 5% of patients who get, or people who get pancreatitis from this and just have to stop them. The statin side effects, while annoying, most people get a little bit of muscle soreness and sort of like achiness. Statins overall don't have a whole lot of short-term side effects. Now, we can discuss the long-term side effects, but short-term, they don't have a ton of side effects. So are they the new statin? Not yet. But maybe, and there's some other things we'll talk about that may help with that. So
in 2026, we're seeing a lot of, and this is the big one for right now at least, is we're seeing a lot of oral medications versus injection. Now the Wegovy, that's the brand name that's just come out on the market, is they're touting it as $149 for 4 milligrams. And I don't think they have a higher dosage than that right now.
Not oral, no, they don't.
I've taken both. I've taken both the oral and the injection. And I will say the oral, for me, now it may work better, faster, but stomach problems
were worse.
Like the injectable just goes right into your bloodstream and it kind of works like that.
Yeah.
The other one goes through your system.
Yeah. So there is pretty good evidence that the heartburn and kind of fullness feeling is worse with the oral versus the injectable. Now that usually goes away within an hour or so. But yeah, that first hour after people take it, they don't like it very much. But then there's a whole flip side of people who don't want to inject themselves, right? There's a lot of people who are like, I don't want any needle. Now, there has been semaglutide, which is the active ingredient in Ozempic, has been around in oral form under the medication name Rybelsus for a long time. It's just that Rybelsus is not on label for weight loss. It's only for diabetes. So Wegovy is the first medication that's been on label for weight loss as an oral medication. The studies are not out yet in the comparison of efficacy. Now, the comparison of Rybelsus oral semaglutide efficacy with any of the injectables, including Ozempic, the Rybelsus is a little less effective, probably because of the efficacy, right? So like the dose you would have to take of Rybelsus to match the dose, especially max dose of Ozempic, is like unimaginably high, and you just can't do it. And so you probably lose a large portion of that medication. The formulation with Wegovy is a little bit different than Rybelsus. So there'll be some things that'll come out over the next few months or years that'll help us determine this. But I think, at least right now, as a generality, the injectables are more efficacious with less side effects than the orals. But you can't really microdose. There's a lot of people out there microdosing or taking like kind of low doses of these GLP-1s because there's good evidence that long-term hypoglycemia or really just keeping your blood glucose controlled and under 100 pretty much at all times increases longevity, right? So there's a lot of people who are taking this not for weight loss, not for diabetes, but low dosing it through a compounding pharmacy for the longevity effects. So
all right.
And there's a famous physician out there who promotes this stuff, but I can't say his name anymore because he was in the Epstein file. So anyway,
there you 2026.
2026.
Striking again.
Yeah.
I don't mind the injection.
Yeah.
Honestly, like I don't like needles.
Sure,
I don't.
Sure.
But it wasn't bad.
Yeah.
I mean, like it's not like a huge gauge needle that you're, I mean, it's just that.
There's some people who are deathly afraid of needles and can't do it. Just like there's some people who can't take a pill. The pill's a big pill, so there's some people who can't take. So it's different ways to take the medications, and insurance coverage wise, like you said, Wegovy's supposedly $149. Now that's just a special coming out of. Is it Lilly that makes that Wegovy?
Yes.
Yeah. So it's a special coming out of Lilly for now until it gets more.
And I'll ask about insurance here down the line because that's a big one for people.
Is,
I mean, I think that's the biggest reason that maybe people don't take it.
Now I think the Trump administration negotiated some better prices, right? So it's not quite as expensive as it used to be for the injectables, but
We'll quickly touch on this one because we've talked about it before.
Yeah.
The muscle loss, metabolism, and the trade-off associated with, again, the face,
right.
Muscle mass loss.
So you have to work out if you're taking a GLP-1, maybe not in the like escalation phase in the first couple of weeks, but you have to work out. Otherwise, you will lose muscle, right? Weight loss if you lose, I think the normal person, if you just did straight up, calorie restriction, I think the normal person, I can't remember the exact numbers, but it's about 70% fat loss and about 25-30% muscle loss. It inverts if you don't exercise with the GLP-1. So you're losing more muscle mass than fat mass. And it's not good. Again, longevity wise, that's not good. So
you've heard the term Ozempic face or whatever, right?
So the way to avoid that is lots of protein and strength training, right? And I'm not saying you have to go out and pump iron for 2 hours, 7 days a week, but you need to keep up a level of muscular and cardiovascular fitness. So and I don't think most physicians are counseling the way they should, right? Everybody looks at these medications as like the wonder drug, and I'm just going to lose a bunch of weight. It is, but it's not necessarily going to get you where you want to be. Like most people don't just want to be thin; they want to look good. They want to be thinner, and they want to be muscular. So you got to stay on top of that.
The forever drug, right? We went to a bariatric conference where we kind of posed the question to people. We said, "Hey,
how do you get off these things?
GLP-1 or right? I mean, that was the question, and I'll link
surgery.
it. GLP-1 or surgery, and they said you're really gonna have to do both because that's the way of it.
And they even said GLP-1s before surgery to lose the initial weight, surgery to lose the big chunk of weight, and then GLP-1s after until you get to optimum weight. So,
is it easier? Let me think about this question, but is it easier for patients who get bariatric surgery to take the GLP-1 rather than not take the GLP-1?
So
you see what I'm saying?
So the majority of people who have bariatric surgery have smaller meals because they have a smaller stomach for whichever bariatric technique you choose. It basically shrinks the size of the stomach, the amount of food you can eat. So I think they're better with the GLP-1s than like you or I would be because we're used to eating big meals. People who have had bariatric surgery are used to eating tiny meals. So there's probably help there. It probably helps with that. But compliance and ability to stay on it is I think about the same whether you've had bariatric surgery or not.
I think the biggest question for me, right, and nobody knows this because it's so new, how long as a researcher does it take for these medications to finally catch up to the research? Like, does it take 10 years for research, 20 years? Like, when do we know, hey, there might be some lifelong side effects?
So they've done retrospective studies with the GLP-1s for diabetes, but they weren't using those higher doses, and they also weren't using it for weight loss. And the side effect profile is actually pretty good. Long-term side effect profile is pretty good. So I would assume it's probably similar to that, but it takes, you're talking about having to have people, acceptance, and then getting a critical mass of people who are taking it, and then doing the prospective and retrospective studies. I mean, you're probably a decade, 15 years before you know.
So maybe less than a generation.
Yeah. Oh yeah. Definitely less than a generation for sure. But it takes some time. Is any medication without side effects and without risk? No. These seem to be fairly low risk overall. Now, do you have to take it forever? The forever drug. So there are a lot of people out there who are using these protocols to get off the drugs. And what I've read anyway that seems to be the most effective is a tapering and then coming off of them. And if you start to get a rebound, you go back on the low dose for, a month and then taper back off and back on the, it's almost like quitting an addiction, right? It's like quitting smoking, right? You got to back down. Oh, well, I'm going to go back on for a little bit and then off and then on and then off. That's typically the way that people come off of them.
It's really interesting because I think the general public, right? And we'll talk about the cost in a second, but the general public, there's almost like this perception out there that this is the fountain of youth pill, like you take it, you live forever. It's not, though, right?
It's not that simple.
It's not.
There is one other side effect that a lot of people don't talk about, and it's relatively rare, and it almost only happens in diabetics, but there's retinal changes with especially the injectables. The orals not as much, but the injectables, there's some retinal changes. People actually can have some blindness. So that's one big thing, that if you're diabetic and taking these, you got to be really careful. Any vision change that you notice at all, tell your doctor and potentially get off the medication. So I would be remiss if I didn't at least mention that.
This is probably the biggest question that people have. It's, in my mind, the biggest question that I have. And this is the fifth topic. The price.
Yeah.
Why is it so gosh darn expensive? And if it's so widely used, why are we paying $500, $1,000?
Yeah.
I picked up, the Wegovy or whatever, and it's like $1,600 without the Eli Lilly thing. Why are insurance companies, if you're not pre-diabetic,
right,
why are they not offering this at a lower cost?
Yeah. So a couple of things, and this was interesting. I actually heard this story. Or heard this description when I was at the ASA Advanced Conference 2 weeks ago now in Las Vegas. And so the reason that most insurance companies don't care about long-term benefits of things is that the average person changes insurance every 3 years. So you either change your job or your job finds a cheaper insurance or whatever. So if you're on, not to pick on anybody, but let's just say you're on Aetna right now, it's likely 3 years from now you'll be on a United Healthcare. And so Aetna, unless there's benefit, the actuaries find a benefit in those 3 years, they don't care, right? So there's no reason for them to bring the price down there. And all these insurance companies also own the PBMs, the pharmacy benefit managers, which were supposed to reduce costs and actually increase cost. And we can talk about that. That should be a whole podcast on its own of these pharmacy benefit managers, vertical integration and all that craziness. But okay, so that's why the insurance companies don't care and won't bring the cost down. Why are the pharmaceutical companies increasing the cost? Supply and demand, right? They're the hottest thing out there. It's like saying like during COVID, why was a mask expensive? Because everybody wants a mask, right? So why are the GLP-1s expensive? Because everybody wants the GLP-1s. So that's probably a big part of it. Now, Medicare and Medicaid are covering a portion of it because Trump negotiated some price costs and did some things. So they are covering a bit of that. So, and then the other thing is, it's a little bit touchy because you don't want to be labeled with diabetes if you don't have diabetes, because then that can cause you all kinds of problems down the road. But if by chance you were to have a high blood glucose on 2 separate readings, your doctor might say, oh, he's pre-diabetic and let's get him on a GLP-1, and then it would be fully paid for by insurance. So now what they're doing is they're going back and they're saying, well, you can't do a GLP-1 until you've tried all these other like blood glucose lowering medications. There's a thousand other of them out there, but metformin is like the big one. So you got to try metformin for a month, and then you got to try glipizide for a month. This is the whole thing. So that's what they're doing. The insurance companies are now doing that. But there are other ways around it that a lot of people have found, is the compounding pharmacies, right? So it's still expensive, but it's not like full on expensive.
Because it's not 100%.
Right.
The name brand.
Right, correct. So it's basically doing off-label. But okay, wait, go ahead.
Yeah. So while I was picking up this other brand, I asked the pharmacist.
Yeah.
I said, what do you think about
the
so and so?
Yeah.
Man, was she hesitant.
Yeah.
She was like, yeah, it's less, but I don't necessarily trust those.
Well, so compounding pharmacies don't follow all the same rules as let's say FDA approved products, right? And so you don't necessarily know if you have the actual amount that's in the compounding. Now, I would not go so far as to accuse them of being unethical and not putting any in there, but
you've heard stories.
I've heard stories. Yeah, exactly. So be careful with the compounding. Although there's these national companies like Roe and what's the other one? Hers or whatever. Those are probably better because they're a national company that like actually cares if they get a bad review and would get multi-million-dollar companies that would be sued and have to lose money, as opposed to your corner compounding pharmacy who, what are you going to do, So.
Right. Well, and I think as you look at it, right, it's like, okay, they're expensive now, and I'm going to go a few good men on you.
Uh-oh. You can handle the truth.
In your professional opinion.
Yeah.
Professional doctor opinion.
Uh-huh. I'm a doctor, not your doctor.
Correct.
Yes.
Do you think or foresee with experience, do you think these come down in price?
Well, they'll come down as soon as they're generic. So I don't know when the patent runs out on semaglutide, but as soon as it does, every company out there is going to make it. Yeah, and it's going to, usually the price drops 10 times. So
10 times.
Yeah. So if it's $1,000,
be $100.
$100. Right. That's usually what happens when something becomes generic. So I mean, we could look it up. My guess would be the first line ones like Ozempic and Rybelsus probably go generic in the next 4 or 5 years.
Okay.
Be my guess.
I mean, everybody. I think this is a barrier for a lot of people.
Yeah, it's the cost. Absolutely. Yeah,
it's a barrier for a lot of people.
Yeah. And so it'll be much less expensive once they go generic, right? This happened with all the major medications. Yeah. Once the statins started to go generic, everybody got on a statin. Once like the ED drugs went generic, everybody got on ED drugs. So it'll happen.
The sixth question or topic that we want to tackle here is mental health around it.
Mm-hmm.
Do you think the GLP-1s, and we talked a little bit about this, is changing some of our DNA in our brain, and is it changing some of our mental and
I don't think it's changing DNA, I don't know. I don't know all the studies on the epigenetics of the GLP-1s. I think what it's doing, though, it's changing our relationship with food. So the problem we have is we were designed to eat intermittently and to see food not as a social event and something that's around all the time, but food as like you go, kill the woolly mammoth, eat the woolly mammoth, you might not eat again for
survival,
5 days or a month or whatever it is. So I think what it does is when you're not hungry with these medications, you learn that you eat to live, not live to eat, right? And it's cliche, but that's kind of what happens, right? Is that you're like, okay, well, I should probably eat because, I'm not super hungry, but I should probably get some protein in, as opposed to people who just like wake up and they're like, all right, I want my latte and I'll have a bowl of cereal. And then as soon as I get to work, I'll have, 3 candy bars. And then when I, have lunch, just
so you could argue that it's helping our relationship.
I think
with food.
I think it's helping our relationship with food in terms of cravings of food, in terms of timing of food, in terms of realizing what food is actually for. Now, you can go too far into an eating disorder where you just don't eat because, people say, and I've microdosed these too, like you're just not hungry. So you could go a whole day and not eat if you don't think 100%. About it. So I think anything can go too far, right? But I do think that it does make you consciously think about what you eat and when, which we don't do, especially in America. We just you can walk I can walk outside the studio and eat some candy. And then as soon as I walk in the door at home, there's a bag of chips. Like, yeah, they're masa chips, so they're not terrible for you, but a bag of chips. So, I think that there's probably positive effects of these more so than negative effects. We just got to be careful we don't swing too far.
Social media.
Yeah.
It's all over the place.
Yep.
Right? You mentioned hymns and whatever, right?
Yep.
Some of these companies that are, going nuts and viral on social media, how is it helping or hurting?
Yeah, so
the misinformation.
So there's some things. So the microdosing trend, now this will be maybe a little bit controversial, but the microdosing actually probably makes sense for people who are not obese. So microdosing these, again, one of the biggest predictors of longevity is regulated blood glucose. So if you can microdose these and keep your blood glucose around 100 almost all the time, you're likely to live longer.
Okay.
So there is probably some benefit to microdosing. Now, how much is that? When do you take it? How long do you take it? Are you becoming hypoglycemic? Like there's some things you have to think about, but microdosing is probably reasonable. Now, should people be using these to lose that last 5 pounds? No, right? So you're committing yourself to a drug that has side effects and potentially you'd have to be on for a long time. And so should you be going from, like for me, my ideal body weight's probably like 170. If I'm at 175, should I be taking a GLP-1? No, absolutely not. That's not healthy, right? And so there are a lot of celebrities, and that's kind of the next thing we're going to talk about, who are like, oh yeah, I just, I pop on these for a few weeks and I lose my 10 pounds for the Grammys and then I drop off of them. Like that's an unhealthy way to do it, right? So the celebrity influencers.
And that's what people are seeing.
Right. That's the problem, right? So if you are obese, even overweight so if your BMI is like 28 with multiple comorbidities that put you at risk for cardiovascular disease, that's a really good reason, even if you're not obese, to take a GLP-1. If you're 20 pounds overweight, even if your BMI is only 26 or 27, probably still a decent reason to take a GLP-1. But yeah, I can't even think of a celebrity, but if you're a celebrity who's already thin, you want to lose 5 pounds to fit into something for an event, that's just not. I mean,
we saw what Heidi Klum was wearing last night for the Grammys.
I don't watch that.
It was weird.
I don't watch that crap. So.
It was weird. It looked like a knight's outfit. Like she couldn't walk.
Oh, jeez.
It was like metal. Yeah.
I probably shouldn't bring this one up, but there was an interview I saw with one very controversial person interviewing another very controversial person, and one of the controversial people said that the goal of fashion is that the fashionistas hate women and they want to make them look as dumb as possible. I mean, look at what some of these people are wearing.
100%. You can go just Google Heidi Klum Grammys.
Well,
and
any of them.
Yeah,
what
any
of
them,
these people wear. Like half the time they don't have anything on, which is ridiculous. Or like they've got these goofy, they're supposed to look like a pirate or something. It's like, who thought that? Oh yeah, that's high fashion to look like a pirate.
No.
What in the world?
I'll just stick to my comfort.
Yeah, exactly.
That's what I'll stick to.
Exactly.
The final question has to do with you, right?
Okay.
What do you wish that patients knew before starting these GLP-1s?
Okay. So as a physician in general, what I would want patients to know is that this is a commitment. This is not just a quick fix all. This is a commitment. It takes several weeks to months, and there is some dedication to actually either taking the shot or taking the pill. And then if you want to be healthy, not just thin, it takes the commitment of forcing down some protein and exercising. So there's a commitment, right? You're also not going to go from 500 pounds to 150. Right? Like that is not a reality.
Happen.
It's just not going to happen. There's going to have to be some other things that happen, or you might, but it might take you 15 years, right? So on average, people lose about 15% of their body weight in a year. So if you're, 500 pounds, 15% of that means you're going to lose 75 pounds, but then that cuts at least in half every year after that. So if you're on a GLP-1 year one, let's just do something more reasonable, 300 pounds. In year one, you lose 15% of that, right? That's 45 pounds. Year two, you lose another 20. Year three, you lose 10. Year four, you lose 5, right? So like there is diminishing returns. So you're going to have to do some other things besides just GLP-1s, unless you only need to lose 15 or 20% of your body weight. Then you're probably fine. Nutrition wise, you have to get protein in. You can't, so you're only going to be able to eat so much. And if you're eating fried chicken and, candy all day long, you're not going to do well. You need to make sure you're getting in, like salads are a big thing to make sure that you're getting the nutrients from that. And then like low fat, high protein meats are super important. So like a good, not terrible for you beef jerky is a really good thing for somebody on a GLP-1 to have. Like if you can get like a low fat, even like a turkey jerky or a chicken jerky that's not like super processed. There's a few brands out there. That's a good one. And then not everybody's successful. People fail on the GLP-1s. So probably the biggest thing that happens, there's several phases of failure. Acute failure, meaning right away, is that they can't tolerate the side effects, whether that's pancreatitis, whether that's nausea, feelings of fullness, even vomiting, or
because the dosages get higher.
Right. So some people get dizzy from it. So there are some side effects. So that's your acute. Your subacute is that some people learn how to eat through it. So even though you're on it, if you eat a lot of small meals, like you eat a little bit of something now and then a little bit of something in half an hour, a little bit of something half an hour, a little bit, you can eat through it, right? And we've seen this with the weight loss surgeries, but people are doing it too with the GLP-1s. Okay, so and then long-term failure is the rebound from coming off of it, right? So there are like 3 phases where you could fail with these. The success rate's pretty good with these as compared to a lot of other medications. And again, they're pretty good in terms of benefit side effect profile. So like this is not like, and no shade on anybody who's taken or who prescribes phentermine or Adipex, but that's one that is kind of good initial benefit, but then it goes away pretty quickly and there's a lot of side effects with that, right? So this I think has a really nice benefit to side effect profile. Perfect, no, but better.
I loved our conversation. This was good.
Yeah.
This was really, really good.
And we've never really talked about the GLP-1s before.
Right. Never.
Never.
And we might not talk about it again, or we will talk about it next season.
Yeah, exactly.
Really good to discuss.
Yeah.
Of course, if you want more information on us actually talking to a fitness provider.
Oh, yeah.
We've done that in previous seasons. We can link that below as well. You can see that show. So really good conversation. And again, see your doctor.
Yes. I am a doctor, but not your doctor. So see your doctor.
Dr. Brian Schmutzler, I'm Vahid Sadrzadeh. This has been Going Under Anesthesia Answered, brought to you by the Butterfly Network.
Yes, we are.
And we'll see you in the next one.